Hi everyone, welcome and thank you for joining us. The Powerhouse acknowledges the traditional custodians of the ancestral homelands upon which our museums are situated, and we pay respect to their elders, past, present, and future, and recognize their continuous connection to country. My name is Catherine Poltz. I'm the science producer at the Powerhouse and the programmer for the Sydney Science Festival. Throughout National Science Week from the 14th through the 22nd of August, we've been broadcasting live conversations with experts to address some of society's biggest challenges and the positive contributions made by science and scientists. Tonight, our program addresses the COVID-19 pandemic and the role of science in understanding the origins of the disease, vaccine development, and pathways to mitigating future outbreaks. COVID is front of mind for all of us, and we've had a lot of questions come through already from the audience, but we will also be taking live questions from Facebook that we will pose to panelists towards the end of the discussion. I'll now introduce Dr. Norman Swan to start the program. Dr. Norman Swan is a multi-award-winning producer, broadcaster, and investigative journalist who's renowned for delivering straight, honest, common-sense health information. When the news of COVID-19 unfolded, he stepped up to answer Australians' questions and cover the key issues with clear, evidence-based information across multiple programs and platforms, including co-hosting the highly subscribed daily CoronaCast podcast. We are so pleased to have had the opportunity to work with him and our panelists on our program. Welcome, Norman.
Thanks, Catherine, and welcome to everybody watching us. Sorry, it can't be in person, but it's the circumstance of the day. Three great panelists for you today, and as Catherine said, we welcome your questions and try and have this as an interactive conversation. Catherine, just on Slido, you going to tell people how to go into Slido, or that?
Just into the Facebook comments.
Okay, all right, fine. So our guests this evening are Professor Dominic Dwyer, who is a medical virologist and director of the Public Health Pathology for New South Wales. And as you might imagine, rather busy. Dominic, thank you for giving up your time this evening. I can imagine that every minute of yours is fully occupied, but thanks for doing this.
Pleasure.
Professor Tony Cunningham, who is a medical virologist also and is director of the Centre for Virus Research at the Westmead Institute of Medical Research. Welcome, Tony. And Professor Raina McIntyre, who is Professor of Global Biosecurity, directs the Biosecurity Program at the Kirby Institute, a vaccinologist and an infectious disease expert as well. Welcome, Raina.
Good evening, Norman.
Dominic, on a night like tonight, we just can't not talk about the situation in New South Wales. And you've been doing the amazing numbers of tests coming through to private and public pathology laboratories. What I've been noticing rather disturbingly is that despite the number of tests, the positive rate is going up, which is always a worrying. So it's still well below what the World Health Organization says is a worrying, which is 5%, but it is going up. Just give us your take on where we're at in New South Wales at the moment, given you're observing the testing situation apart from anything.
Well, my take at the moment, Norman, is that it's widespread in New South Wales. So we've seen over the last month or two, starting in eastern suburbs, then into southwestern Sydney, now into western Sydney, and I think really concerningly into much of rural New South Wales, in particular Central West, the far west, Broken Hill, all those places around Dubbo and so on, where we do know that we've got some pretty problematic communities in terms of general health. So I think that it's widespread now, and I think that is really a big problem.
And I should have acknowledged country as well before I started, and I certainly want to, I'm on Gadigal land, the Eora Nation, but I certainly want to acknowledge the Wiradjuri people in New South Wales who are really doing it tough in Western New South Wales and in communities where, the Aboriginal communities, really were magnificent in terms of community-controlled health organisations and organising themselves in the first wave of this pandemic by isolating whole communities. But now that it's getting into communities, it's just really a huge issue, which we might return to. Raina, what's your take on where we're at?
Well, I think it's a very serious situation in New South Wales. It's also a risk to all the other states and to New Zealand, as we've seen. We've had, an outbreak seeded to New Zealand as well. I share Dominic's concern about the regions. The thing that's different about Australia is the vast distances. So, if Dubbo Hospital goes down, it's not like you can drive 30 minutes to the next hospital as you could in Europe, for example, in a country town. Often the even smaller hospitals will rely on a regional hospital like Dubbo Hospital, and if they're facing bed block, they might be also unable to provide that surge. So it's a really very serious situation for the regions, but also serious for Australia. The fact is we're not like the UK in the sense that we haven't had massive amounts of infection. So to think that we can just open up in the same way as the UK at the same vaccination rates is naive, because we don't have the immunity conferred by natural infection anywhere near at the same level. So to relax restrictions, to just copy the UK model and relax restrictions at the same point would be extremely dangerous.
Because there's no background immunity to build upon. Why do you think politicians don't get exponential growth? One of the reasons for going early and going hard is that exponential growth, people think of the exponential growth as being the hockey stick, the vertical line. But we've had exponential growth since the very beginning, and it's very slow at the beginning, and then it speeds up as the numbers get larger. What is this block against understanding what's relatively simple maths?
Look, I can't speak for politicians, I'm afraid, but the reason the exponential growth suddenly gets much, much worse is when your ability to trace contacts and isolate cases and do your testing, etc., is exceeded. When you can't do those two things, are super influential in controlling the epidemic. Being able to identify every case through testing and being able to trace and quarantine the contacts. The minute it gets too big for you to do those two things quickly and efficiently, it just blows out. Which is why the more uniform, stringent restrictions are required especially when you approach that point.
At what point do you think it's going to peak? What sort of numbers?
I don't think it's peaked yet. It's hard to say. It really depends on the response, right? It depends on what interventions are taken at each point in time. So it's not a fixed or predictable thing. You can't really predict the peak until after it's happened. You have to see it decline in a sustained way to say that was the peak.
So, Tony, I was interviewing Eddie Holmes at the Sydney University, who's a world authority on viral evolution, the other day, and he was saying to me, and he should know, he was the first one to distribute the genome to the world. He was saying that we've never seen anything like COVID. This is entirely new and surprising, and it's just constantly surprising us. Do you agree with that in terms of this virus?
Yes, indeed. And I think Delta's surprised everyone. And I think that's been part of the problem, is that we seem to it happened with HIV. We learnt in hindsight from HIV, and we're learning in hindsight from this virus as well. Tony Fauci and others thought asymptomatic infection wouldn't occur based on SARS-1. We based a lot of our planning on the first outbreak with the Wuhan strain, the earliest strain, and now Delta has come along with 1,000-fold higher levels of virus in the nose, with far greater infectiousness, probably the second most infectious virus after measles that we know. And
really?
Younger people, yeah. Well, it's 1 in 8. It's about so measles 1 in 18. So this is a highly infectious virus. The other worry, of course, is that it is to some degree infecting people who've been immunized, and that seems to increase with time after immunization has just been published from the UK. The latest,
although paradoxically, the AstraZeneca vaccines seems to not wane as fast as the Pfizer.
They're converging. You know, they get down 3 months to 75% for Pfizer and 61 for AstraZeneca. So we've got a little way to go to see how that goes. I think one encouraging paper, it's only one paper, comes out of Singapore, suggesting that Pfizer immunized people might, although they start off with the same levels of virus in the nose, they may actually drop off faster over time if you're immunized compared to unimmunized people. So maybe we'll see less spread. Does look as though in Iceland, as Rainer said, there might be a peak, which is encouraging as people have been worried about that particular outbreak.
And there was a peak in Britain for at least for a while before this AY3, this subvariant of Delta seems to be emerging, but we'll come back to that later. Dominic, people are obsessed with where this came from. In fact, I went on a comedy show a couple of weeks ago, and the first question I got was lab or rat, lab or bat. I actually didn't hear him properly, and I jumped in and said lab. I didn't know what he was talking about, but he was actually talking about where it came from, which I don't necessarily think. I'll come to Ryan in just a moment. Now, you went on a WHO mission there, which was highly controversial. What was the objective of the mission, and how did you do, and how did you carry it out? Because it was in part to find the origins of the virus.
Yeah, look, it was about examining the origins of the virus, and that's really important to understand because a lot of people felt it was about the responses to the pandemic, and that's a very different kettle of fish. So it was about the origins. We started off talking about this for some months before we went to China, all done on Zoom, of course, and then we went to China, and of course that was limited for a range of reasons, including the fact that they were still dealing with outbreaks themselves. So it was all kind of very much hotel quarantine based. The terms of reference were set by the WHO. The WHO is like any organisation, political. So the kind of references and terms of reference were fairly tight, I think, in terms of what we were allowed to ask. Then we went there and, we asked the questions. We tried to we did assess the evidence, much of which was provided. When you look at all the other coronavirus outbreaks and new viruses that emerge, and indeed nearly all the viruses that we've known about in the last 40 to 50 years, they all come from animals. And they come from animals. The way they come may be different. The way they spread in humans might be different, but that's basically where they come from. Now, of course, there are other theories as to that, and we took the view in WHO to be aggressive about asking questions. The Chinese weren't necessarily pleased with some of those questions, and that was part of the tension. But we did explore the laboratory leak idea. We did explore some of the other ideas like frozen food, et cetera, But really the evidence then, and in fact the evidence now over the last couple of months, continues to point towards an animal origin. You can't dismiss the other ones, but that's the most likely.
Yeah, because they were doing these gain of function studies in the Institute of Virology. In other words, if you're to explain that a little bit to the audience, if you're doing sort of viral surveillance in the environment, you want to know what the genetic signature might be of a pandemic virus. And with American researchers, they were fiddling with the genes of the virus to see if you could amp it up to be pandemic and what the kinds of that were. So, I mean, they were playing with fire in a sense in the institute in Wuhan.
Well, look, yes, they were. And of course, we weren't charged with doing a forensic examination of the laboratory. That's a very different sort of process altogether. But we were initially told we couldn't ask questions about it, but we did, and we pushed quite hard on various things. But you need a whole range of things to happen for it to be a laboratory leak. You have to have the virus in the lab to begin with. You then have to have an accidental spread into a human, which can happen. We know that happens in laboratories. Then you have to have spread in the community. Then you have to have ongoing significant transmission in the community. Then, if it has leaked from the laboratory, you then need, if there's a cover-up of that, then you need a whole state apparatus to control all of that. And so, you know, to me, there's too many things that you need for it to be a laboratory leak until further evidence comes to hand. But when you look at what's been happening now, all these things with gain-of-function studies, the various features of the virus that make it transmissible, the way it binds to receptors, the way it gets into cells. Yes, you can probably do those with gain-of-function studies, but all of those features are present in viruses in the wild. So they are present in bat viruses, the furin cleavage site, some of these other sort of amino acid changes that are significant, they are present in the wild. So, you know, why do you have to postulate another way that they could enter into humans? Possible, but unlikely.
Raina, I've interviewed Michael Osterholm at the University of Minnesota, who's a world authority on pandemics and infectious diseases. He, like you, is extremely worried that if this one wasn't a lab-based pandemic, the next one could be, and he's not an hysteric. You know, he's a cool, calm scientist. Just talk us through what the risks are currently that we're facing, possibly for the first time in medical history, that, you know, if it wasn't this time, it could be the next time.
Well, the advances in technology and biology have been really quite phenomenal over the last 10 years particularly, but even over the last 20 years. It's quite analogous to cybersecurity, but probably in biological sciences, we're 10 years behind cybersecurity in terms of thinking about governance and managing risk. So essentially, in 2012, this technology called CRISPR-Cas9 became available, and it's really had, you know, enormous impact on medicine and, you know, treatments and cures and so on. But it also enables genetic engineering for nefarious purposes as well. Not to mention the fact that we have open access science, which means that methods for doing different kinds of gain-of-function research and or genetic engineering are published so that other people can look at those. And my view is always, you know, if you publish a method of how to hack a bank account on the internet, I think it, you know, it's pretty obvious someone's going to use it. And I think it's the same for biological research. We've seen also David Evans, who's the virologist in Canada, who synthesized an extinct orthopox virus, very closely related to smallpox, in 2017 in his lab. Has actually said it will not be possible to eradicate any virus ever again because you can simply make them, right? You don't need to break into CDC or Vector in Russia to steal variola virus, the virus that causes smallpox. It is possible to create it synthetically in a lab. And I think the other issue is the accessibility and the cost of, again, it's a paper that David Evans had written showing the cost of the materials and equipment required to do some of this research has exponentially declined over the last 10 years. So it's getting cheaper, more accessible. You can get lab-in-a-box kits. You can, you know, think about the drug trade, right? People are running meth labs in their backyards and in their homes. Do-it-yourself biology has exploded internationally. We have labs in Sydney and Melbourne that are do-it-yourself biology labs. They're only meant to operate at the lowest level of biosafety at BSL-1, but, you know, there could be labs that are not official, just as there are drug labs that are not official. We know that there are terrorist groups who've stated their intent to wage biological warfare on different nations or populations. So the intent is there, the capability is there, and I think...
Is it controllable? I mean, you could, to some extent, you can control. We're not being very good at controlling development of nuclear bombs, although it is difficult. You've got to centrifuges, there's a certain equipment you've got to do, you've got to find uranium, you've got to refine it and so on. So there are a lot of complicated steps that require significant infrastructure to get a nuclear bomb. What about this? Is it controllable or is the genie out?
I think we can't go back in time. These technologies are here to stay. They're important for medicine. We need these technologies, but there's an element of governance and risk management that is not well addressed. The US is the only country that's really comprehensively tried to address these risks, going right back to the anthrax attacks after 9/11. They formed a National Science Advisory Board on Biodefense, and they've sort of thought about it and gone through different, policy guidance documents, etc. Even the NIH has guidance on gain of function research. We don't have anything like that here with NHMRC. We've actually relaxed export controls on genetic materials, etc. So, and it's no one country thinking about and developing frameworks for risk mitigation is not adequate, because these are global threats. A virus that's contagious, as we've seen with SARS-CoV-2, will spread around the whole world. So research done in one country can affect people in other countries, which is also an ethical dilemma that we haven't faced before. A lot of this kind of research is dealt with animal ethics committees, and yet they could result in harm for humans. It's not even considered in those committees.
Tony, I want to come back to the current situation, because it seems there's a paradox here, is that, one is that while we've got a new virus on our hands, which is surprising us all, I don't think there are many public health textbooks that will have to be rewritten as a result of this. It's behaving as pandemics have for centuries. And if you read Daniel Defoe's Journal of the Plague Year, it reads like COVID-19, January, February 2020. So I want to get a sense here of whether science is going to save us versus human behaviour, because what we're seeing now in New South Wales are attempts which you could criticise for not being enough early enough to change human behaviour, but whether science is going to save us in the end, or it's about the way we live, or it's an intricate mesh of the two. What's your reading of all this?
Yeah, we're strange creatures, aren't we, really? The amount of,
yourself, Tony.
the amount of stuff that circulates about conspiracy theories on social media that's actually encouraging behaviour that's not in our best interests, particularly with regard to vaccines, is extraordinary. So we have got a race on. We've got a race between the capacity of the community to tolerate the lockdown conditions, and I might say people with economic pressure on our political leaders, and getting enough people immunised as quickly as we possibly can. It's really bad luck. We've had a lot of bad luck with AstraZeneca and also with the failure to get the doses from Europe initially, and also the amount of publicity that's been given to a side effect of AstraZeneca that amounts really to 1 and 1.5 people in a full Sydney cricket ground in terms of incidents, and a lightning strike in terms of death. So we have had that sort of bad luck. We've also had bad luck that Delta got out when it did, just one breach. And if this had actually occurred a couple of months later, then we might have been in a better position. So the only good thing about this that I see is that the amount of vaccine concern about vaccine uptake, I'm not going to use hesitancy or Julie Leask will kill me, but vaccine uptake is changing. We saw this in India, where 91% of people after their outbreak wanted to be immunized. I think what worries me is that we've got inequity of medicine again. We're seeing 10 to 20% people immunised in the southwest in the Fairfield district, and 50% in the wealthier parts of Sydney. So I think focusing on this is really important. It really worries me that we did not ensure that vaccination was mandatory for aged care workers, for healthcare workers, and I think that's an outdated concern. We've always been concerned about mandatory immunisation, but this is something that's quite different, and I can see the game changing, Norman.
Yeah, and just on the statistics, my understanding is that the portion of people who say they will never be immunized has dropped from about 10% to between around about 7%. It varies around the country, so it's getting pretty low. People who are not willing to be immunized. We've got a lot of questions coming in. I mean, we could talk forever about this, and there's issues there. One question, Dominic, is because you've looked at the history of this, and Ryan, well, all three of you have, is how did the Spanish flu end?
Well, look, if you see what happened with the virus itself, it didn't change very much, funnily enough. There were a number of big waves of infection over the couple of years after it first emerged, and some of the second and third waves were worse than the first one. But when influenza was first isolated from a human in the mid-1930s, that virus was virtually the same as a 1918-19 H1N1 virus. So it's really remarkable that the virus didn't change that much, but its impact on humans did. It reduced. Whether that's because people were immune, because they've been exposed to it over years, I don't really know. Influenza is different. And we know that with the 2009 swine flu, that virus too hasn't actually changed very much, and certainly didn't change for the first 6 or 7 or 8 years. Yet and that admittedly was never particularly pathogenic. So I think it's the H1N1 virus from 1918 stayed like that for decades and decades. It wasn't until the 1950s that it went away, but its effect on humans did change during that time. Whether that happens with coronaviruses, I think, is actually unknown.
So, Raina, when I was at medical school, we were taught that there was this dance when you had a new organism, there was a dance between humans and the organism, the host and the infectious agent, and they would come to some sort of symbiosis, and the agent would become less dangerous and we'd learn to live with it. That doesn't seem to be happening with coronavirus, and some people think it might never happen.
Just wonder.
Well, in actual fact, sorry, Tony, you go ahead, Tony.
No, I was just going to make a couple of extra comments about the 1918-19 flu. It did subside, Dominic, didn't it? In but with a whimper, not with a bang. So there were 2 to 3 epidemics subsequently out till about the 1923 or so. The other thing is it hit 20 to 40-year-olds rather than people over 65. We still don't understand that. It killed 100 million out of 500 million people. And my colleague Keith Klugman and others at NIH went down and looked at the cause of death. And it was mainly due to pneumococcal pneumonia, which we now have antibiotics towards. So it is a little bit different in terms of the killing power of that epidemic as a virus itself, as opposed to secondary bacterial infection.
And Raina, this sort of acclimatization idea, which a lot of us grew up with in medical school?
So I think that comes from influenza. As Dominic said, that virus didn't go away, didn't change, it was still there. And likely what happened is that humans just, developed some degree of background immunity to it. And the thought is that when a novel pandemic flu virus arises, nobody's got immunity to it, and that's what causes a severe disease. But then they just become seasonal flu viruses, as the H1N1 that caused the Spanish flu did. But I don't think that's the case with this particular lineage of coronaviruses, the beta coronaviruses. There's been no evidence that they mutate to become less severe. In fact, the opposite has happened with SARS-CoV-2. It's become more contagious, more vaccine resistant, and more deadly. So it doesn't seem to be going in that direction of becoming the common cold. What will effectively make it more like a common cold is really high rates of vaccination.
There's one good thing about it, that is in South Africa, the beta strain has faded, and this is the most vaccine evasive strain, and has been replaced by Delta. It's just gone down like
Delta's muscled it out. Another question and I don't know who's been looking at this, so I'll take it from any of you, and I've been wondering this as well, and I can't find good papers on it, the extent to which vaccination prevents long COVID if you get infected. And there was some indications early on that if you got vaccinated and you had long COVID, there seemed to be an immune reset, and long COVID seemed to settle down a bit. What's the current thinking, research on this? Tony, are you across this?
No, I don't actually. No, I don't think we've had long enough to look at this, Norman, that I can see in the literature. I agree with you. It's a really important question. It's really important because younger people are getting long COVID and they're getting it from Delta. I think that's something that we obviously need to look at very carefully, and people are doing it here. Greg Dawes doing this, and others at Kirby.
Ryan?
But yeah, I agree with Tony that you need long-term follow-up. It is a chronic long-term condition. Although when you go back to first principles and, there's data showing that the severity of the COVID doesn't necessarily dictate whether or not you get long COVID. So people who've had very mild infection can go on to get long COVID. So on that basis, it's possible that vaccine escape infections could also lead to long COVID, especially now that we're seeing data that the viral load in vaccine breakthrough cases for Delta is as high as in unvaccinated people, even though it doesn't last as long. The duration of the viral shedding doesn't last as long. So I think that we need a lot more data and longer follow-up really to better understand this.
I think we need to look at this very closely. There's a paper recently looking at and showing a higher incidence, for instance, of cerebral complications than we first thought about.
Yeah, it's an ugly virus. Another question, Dominic, from Thomas, who says, we know that current public health orders aren't working to bring down the numbers, at least yet. Has the horse already bolted? If not, what else can we do?
Well, look, I'm an optimist. I hope the horse hasn't bolted. I think we've got a significant problem, as we've all discussed. I think, again, the key is vaccination, and the key to appropriate public health measures and orders that allow people to not get infected in the beginning and protect certain groups in the community that need protection, such as our aged care facilities and so on. So it's going to be a combination of those. And that's why I think we've alluded to it already, that's why the political response in a sense has been disappointing, because we all know that vaccination's the key. And because we've been tardy in doing that in Australia for various reasons, good and bad, that's what's got us into this sort of problem at the moment. We had vaccination rates like other countries, like Israel. I know they've had other, outbreaks and so on since, but I think we would be in a much better position than we've been at the moment in New South Wales.
Well, it's a population similar to New South Wales, and they're getting 8,000 cases a day and more hospitalizations.
That's right.
So 80% of the adult population is 56% of the total population, and with a vaccine that's only probably only 50% effective at reducing infections, so that means 70% of the population is vulnerable. It's still...
Yeah, well, that's why you need a combination of good public health and traditional infection control, if you like, just like 1918-19, as well as the technological advances with vaccination and boosters and changing vaccines and so on.
Another question is, how at risk are babies and toddlers? We're seeing the age range going down as more and more older people are immunized. There may be a predilection there. In Arkansas, Tennessee, to some extent New York State, you're seeing, I think Vanderbilt Children's Hospital, or is it St. Jude's, is full, not taking new referrals because their ICU is full of children. They seem to be getting double infection with respiratory syncytial virus and COVID. Parents could be right to be worried here. Raina?
Yeah, I think we have to look at what's happening overseas in the US and other countries, in the UK, where there's, outbreaks of Delta in schools, and pediatric ICUs are full. Anecdotally, although I haven't seen epidemiologic data on it, anecdotally it does seem to be more severe. But on the other hand, with any vaccination program, when you vaccinate a particular age group, in this case adults, you will shift the epidemiology into the unvaccinated group. So it pushes the transmission into the children. So I think it is a conversation we need to be having. And I think ultimately we do want our children protected because, they've got their whole lives ahead of them. They've got a lot more to lose, and we don't know enough about the chronic disease burden that's going to result from COVID. And, we want to protect our children from, generational chronic health disease from COVID. So I think, I still, going back to the vaccine issue, I think either Dominic just mentioned we will have better and newer vaccines. It's really important to remember that the vaccine pipeline is never static. Not for any vaccine. There's always new developments and better vaccines coming along. We have, over 200 vaccines in development. There's going to be matched boosters that are matched to the Delta, eventually available here, and that will change things. That will drive the efficacy right up again. So we're not just stuck with what we've got today. There is a cause for optimism, and there is the potential to really, I think there's still the potential to achieve herd immunity, but it depends on selecting the most optimal vaccination schedule to achieve prevention of transmission. And it depends on the levels of coverage. And, if you've got really, really high efficacy vaccines, you can actually achieve herd immunity without vaccinating really young kids. So that would be...
So are you reserved about immunising young children?
No, not at all. Vaccination is a paediatric discipline. The majority of our vaccines on our national immunisation program are for children and infants. I think, these are all new vaccines, so there's more hesitance on the part of the health industry, I guess, to vaccinate very young children because they're new vaccines. And although we know that they're fairly safe, there are rare side effects of all of the vaccines. But I think eventually that we will be vaccinating children, including the younger ones.
Question for you, Dominic, which I'll paraphrase the question, which is that if indeed, not that we want to set aside the warnings that Brian has given us about synthetic pandemics, but let's assume there's an equal or greater risk for future zoonotic pandemics, which is spread from animals. What should be put in place so that we learn from this? What controls can we put in place?
Well,
Bats are throwing off new viruses all the time.
Yeah, that's right. I think there's a number of things. One of the things that was striking about the investigation in Wuhan was both the behaviour of the markets in Wuhan, what was being sold there, how big the population of people was around those markets. So I think for many countries in the world, and that I don't just mean China, but Asia, Southeast Asia, Africa, and so on, like with HIV and bushmeat, the interaction between humans and animals is something that's got to be both studied and probably regulated. China tried to do this after 2003 with SARS. They said that wild animal markets were banned, but they didn't go through with it. And that was a political and cultural kind of discussion that I don't understand. But I think we've got to be really serious about the way we interact with animals, be they live or dead, what we eat, what we come in contact with. And they're hard decisions to do, and they take political will. But I think that's something that's going to be really important. The whole zoonotic transmission of viruses and bacteria and other things as well is really important. And we've had it through history, and we've not been necessarily very good at stopping it. But I think we have to use this opportunity to do it.
So,
Tony?
CEPI has put out some interesting guidelines on this recently.
So just to explain, this is the Coalition
for Epidemic
Innovation.
Yep. And in fact, they funded Paul Young's lab in Brisbane to start on a SARS vaccine before SARS-CoV-2 became available. So he had a head start, which I think is important. And they're trying to look ahead again. And one of the things that they're interested in, which I think is important in this context, is firstly looking at the potential for broadly based vaccines, generic vaccines across all coronaviruses, just like we're trying to do with flu. That's the research base. And the other is the possibility of immunizing animals. Don't know how you do it with bats, but certainly other animals with things like Nipah, etc. May be on the cards.
So I've got a question not for you, Tony, which is just run through the treatment, asking about the treatments currently, and there's always questions about ivermectin. Just tell us what we know.
Well, I can tell you what Westmead does, was I was talking to my colleague about this the other day, and Dominic can correct me if I'm wrong, as he probably knows more, actually, and that is that using monoclonal antibodies, just as Donald Trump got, is important. But in essence, you can't use those in people who have severe illness. You've got to use it before they develop severe illness, before they develop their own antibodies. Remdesivir is still being used. And
it's a pretty crap drug, though, isn't it? It doesn't do much.
Yes, and it's variable if you look at the trials closely. And then dexamethasone is being used in both the pre-ICU phase in some people who are hypoxic, and also, that is low oxygen, and also in the ICU itself. And another old drug has come back into play, and that's a drug against the cytokine. And just to remind everybody, this essentially is two diseases, COVID. It's the nose. You have the receptors for the virus in the nose, then they stop behind the throat, and then they start again in the lungs. And the disease in the lungs is because you don't develop an adequate immune response, and you develop an aberrant immune response, which gives rise to something we see in bird flu called cytokine storm syndrome. So this drug, tocilizumab, is also being used in the ICU at present. We really do not have the sort of antiviral like acyclovir for herpes and also the 20 drugs we've got for HIV. Dominic, do we? We need them.
Do you want to comment, Dominic, before we move?
Oh, look, yeah, I mean, I think the drug treatment of SARS-CoV-2 is ultimately fairly disappointing. I mean, yes, there are some drugs that have an effect in certain types of patients. Steroids, dexamethasone and so on, certainly does have an effect in hospitalised patients, a benefit, but it's not a treatment. It's managing the managing the impact of the infection. So a true antiviral drug we don't have. Now, I'd be optimistic to say that we will develop these. We did for HIV.
Well, Pfizer's developing one, isn't it?
Yeah, they're coming. They're coming. It's just that drug development generally is slower than the new vaccine technologies. But hopefully we will get some, because I think we do need them, particularly the people who are at that tipping point of whether they're going to be admitted to hospital or indeed, if in hospital, into the intensive care. They're the ones we want to get to.
There's a lot of questions about conspiracy theories, but Ryan, the whole ivermectin story seems to have got wrapped up in conspiracy theories and anti-vaxxers saying, well, I'll just take a dose of ivermectin every day, and there's some sort of conspiracy against it, but denying us the truth.
Yeah, that and hydroxychloroquine and bleach, a whole lot of other things. Look, I think there's a lot of evidence that the anti-science agenda is organised, orchestrated. It's a type of information warfare. There's a really good article by Peter Hotez, professor from Texas, who is a tropical medicine specialist, who's written about Russian information warfare against the United States, and just puts down a whole lot of historical facts and, links a lot of events that you'd think were just random things, just random crazy people. But there is actually some orchestration, organization. It's a type of warfare. Today you don't need guns and bombs to win a war. A nation state, you can do it through cyber attacks, you can do it through information warfare, as we saw with Cambridge Analytica. There are a lot of other ways that warfare can be waged. It's called grey zone threats, grey zone war, or that's what the military calls it. So I think there's a much deeper context to it all than just random crazies, and it's had a very powerful influence.
Ivermectin did come out of laboratory studies in a good lab in Monash in Melbourne, but in essence just simply hasn't stacked up, and that antivirals,
I might hand over to Catherine now, who's been taking the live questions and has been coming in to field them to us. Catherine?
Yeah, great. The first question is from Christina, and it really just takes us back to basics. She asks, how are vaccines created and how do they work?
I'm happy to take that if you want.
Sure.
So vaccines basically are created by simulating the immune response your body would make to a pathogen, whether it be a virus or a bacteria, usually by providing some component of that pathogen to the human body. And there are some basic techniques that are used. Some of the more tried and tested methods are protein-based vaccines, where you take a protein from the surface of the virus and you can make it through recombinant technology, or, in the old days, through more old-fashioned ways, like the original hepatitis B vaccines that I got when I was a medical student, was a serum-based one. Or you can use live viral vaccines where the virus is taken and attenuated, so it doesn't make you sick but gives you the immunity. And examples of that are like polio, measles, mumps, and rubella. Sometimes the viruses can revert back. In the case of polio, we do see cases of vaccine-associated paralytic polio, which is why there's a push to move to the inactivated polio vaccine globally. And then you can get whole virus or whole bacteria inactivated by a vaccine. So some of the COVID vaccines are like the one in India, what the Bharat Biotech are made in that way. They tend to be a bit more reactogenic. And now we've got new technologies like vectored vaccines. The vectored vaccines have been around for a while, but you basically take a virus that's harmless, you make it non-replicating, so it can't replicate in the body, and then you piggyback onto it some genetic code for the disease you want the person to gain immunity to. And of course, the mRNA technology is the breakthrough technology, which I think will have implications for all of medicine, for treatments and genetic therapy. And it's a science that's been around for a long time. People have been working on mRNA vaccines for I think about 15 years, but companies like Pfizer and Moderna, the breakthrough was in the delivery mechanism, encoding the mRNA with lipid nanoparticles, which then allowed it to be delivered effectively and deliver the payload and create the immunity. So basically, often you have to have a second dose. The first dose of a vaccine will give you a certain amount of immunity, and then it starts to wane. And then you give a second dose and you get a much bigger response that tends to be more sustained. But for some vaccines, we've got to give 3 or even 4 doses. And you've got what's called a primary schedule, which is the schedule that you need, whether it's 1, 2, 3, or 4 doses to get the required immunity. And then you can have booster doses, which you might need at a particular interval after that to retain that immunity. that's kind
So
of it.
the bottom line is this discussion about boosters is nothing new. And just to add to that is the one part of the trials that they compressed in all the vaccines was called the phase 2, which is where they do look for dosage, what's the right dosage. And what we're seeing now is a bit of a scrabble to find the right dosage for these vaccines. And if we'd had more time, they'd have probably sorted that out first. But now, it's not terribly unusual. Catherine, what else have you got there?
From Angela, still on vaccines, how likely is it that COVID-19 will become vaccine resistant, and how quickly might this happen?
Tony?
Yeah, well, that's our horror. It's a bit like HIV. Our great concern was whether HIV would ever become airborne. Our great horror with COVID is that you mix the spreadability or infectiousness of Delta with the immune evasiveness of Beta, and that could happen. And this is why it's so important to immunize the world. We know this happens in people, we know it happens in populations, and that is that the greater the burden of replicating virus, a virus that's continuing to multiply, the more mutants it'll throw out, like in an evolutionary fashion, the more likely it is then to be evasive of vaccines, particularly if you've got lots of these viruses being produced in Africa, and we've got immunized populations in Europe, the USA, and Australia. There's a real risk that we could develop a spreadable immunoevasive virus.
Catherine?
One from Jennifer. She asks, do we pay enough attention to the morbidities left behind by plagues, or do we focus too much on mortalities?
Dominic?
Yeah, I think that's a really interesting question from Jennifer. I think with most diseases, or with many diseases, there are often unexpected long-term sequelae. And the more we know about diseases, the more you identify them. And in fact, two of the really recent examples that have been quite instructive are both Ebola virus and Zika virus, where we understood the acute disease, but in fact, we now realize that there are long-term complications, long-term reactivations of infection, unusual modes of spread, all of those sorts of things. So we do get concerned with the immediate problem, which is what we have been doing for the last year and a half. But the longer term things, I think, are going to be very important to study. We know about long COVID, but it wouldn't surprise me that there are other long-term things that we're not yet aware of, and I think it'll be really important. And many sort of infectious diseases have these long-term problems that take time to become manifest.
Catherine?
Yeah, and you mentioned it, but the next question is from Jenny about long COVID. Could you tell us a little bit more about long COVID? We're just starting to hear about it. And can you get it even if you're double vaxxed?
I'll let the others talk about that. Rhino, you've been looking.
Rhino, you want to go at long COVID?
I think we already answered that before. We talked
we
about
did.
vaccination
Yeah.
and that we just need longer follow-up, and it's certainly possible to get breakthrough infection after vaccination. And I think we kind of addressed that before.
Catherine?
Great. From Louise, a big one. How and when do you think this pandemic will end?
Yeah, I think, well, who knows? If I knew that, I'd be, famous, have a Nobel Prize or something. Look, I don't know. I mean, I think the history of pandemics generally is that they disappear or they change and become less significant. We know that with things we've talked about, like influenza. I think we don't know that, to be honest, with this one. We do know that there's plenty of other coronaviruses that infect humans that probably started off in a more severe way that we didn't realise. So, look, I don't know the answer to that. I suspect we're in for a fair period of managing this with outbreaks and so on, with getting people vaccinated, with vaccine escape, et cetera, boosters needed, regular testing, all of those sorts of things. One of the things we haven't yet seen, although you alluded to it in New York, is the interaction with other pathogens. So, might we see problems in the future when influenza comes back, or RSV, another cause of respiratory infections? What is going to be the interaction with this virus and them? At the moment, it's all about COVID, but there are other things out there, and how that plays out over the next few years, wouldn't have a clue.
Yes, because what's happened is that the other respiratory viruses have not stood still. So we've only had a few hundred cases of influenza this year, and 2 years ago we had 300,000. So, but RSV is making a comeback, and they are worried about that in the United States with double infection. Eddie Holmes on 7:30 the other night, when I interviewed him, said he's given up on prediction with COVID. He's just not prepared to do so, at least in the near term. Although he suspects that what will happen is an influenza-like. Those are very different virus from influenza, but it will look a bit like influenza eventually, where you'll get mutations each year, but you might have pandemic threats every so often, just as you do with influenza, where there's a significant mutation and you've got to scrabble to actually develop new vaccines rather than your minor changes. But he would not be held to that in any shape or form. Catherine?
Just a few more questions. One from Jennifer. If there's one thing that you think we could have done differently during the pandemic, what do you think that should have been?
Stop that person from, make sure that the person who actually was initially infected with Delta was wearing a mask and immunised.
Raina?
Yeah, I think Tony's one's hard to beat there, but I would have liked to have seen a more determined and concerted effort to get the vaccination program started, to diversify the vaccine supply, and to do it the way that Israel did, or the US in terms of vaccination. Yeah.
Oh, well, I've got a bit of a shopping list of those, but I won't go into it. But, going back to what Tony was saying, I would like to ask why the Sydney Airport Corporation wasn't protecting the people that came and worked on their site, and insisted on, why they didn't insist on proper care of people who came to work there. Because that importance of providing a safe work environment, we discuss a lot in the healthcare industry, in our hospitals and so on. And I think other organisations need to be looking at it pretty closely as well, because the failure to do that is what started this off.
I think the other thing to say is, in the aged care sector, the aged care workers under Commonwealth purview, as opposed to those under state purview, we could have done a lot more there in terms of protecting people. Aged care workers moving from one aged care facility to another and taking the virus out back into the community, particularly in the first round, was, I think, a major issue. Perhaps not so much with Delta.
And I think I'll choose not to answer that because it'll get me into trouble. Catherine?
I think that's probably a good place to end our audience questions on. I'd like to thank Norman, Dominic, Raina, and Tony. Thank you so much for sharing your expertise with everyone watching tonight and for having this conversation with us. Norman, I did want to ask you, we've been talking a lot about health in COVID right now, but you also have just written a book about improving our health more generally. Do you want to just tell us about your book?
Oh, it's called So You Think You Know What's Good For You, and I wrote it partly as occupational therapy. So I don't think I mentioned COVID-19 once in the whole book. So it's all about busting myths and making you less anxious about general health things. People are just too anxious about things in their health that they don't need to be anxious about. So only worry the things that count. And I cover a lot of ground in it. But so that's what I was. That's what's behind that book there. And I originally wrote it for millennials who are really health conscious and switched on to the health and well-being. But I realized that us oldies are interested in those themes too.
Particularly if you've got children who educate you.
Yeah, that's right.
So great. Thank you, everyone, for joining us, and thank you to our panel, and we hope you have a great night.
Yep, thanks. Have a good weekend. Thank you very much, everybody.